Hi, everyone. We're going to do the first couple slides of the diabetes lecture and the thyroid lecture, and then also the endocrine and other hormone lecture, and that's going to be the lecture bite. So I'm sort of just doing a little bit sort of free flowing here. I'm not exactly sure how far I'm going to get on each one, but I want to just watch my time so my lecture bite video is not very long. So we're going to do a little bit of review, things that we might have touched on, you might have heard in medical history, medical emergency, I mean, and then also maybe just thinking about patient care. So three important questions to ask your patient in general, as we think about our patient's medications are, what medication do you take? Why do you take this medication? And did you take the medication today? Those are all really important questions that you want to ask your patient. The objectives for this lecture are as follows, but I'm not going to go through all of these because some of this I'm going to lecture in class. And I'm not sure how far I'm going to get on this lecture bite. We're talking about diabetes. So some fast facts about diabetes current for 2025. Every year, this number goes up. We're up to 38 million people, roughly, with diabetes in the US. That's about 1 in 10 people. 1 in 5 people do not know that they have it. And prediabetes is even higher, getting close to 100 million people. That's almost a third of, a little less, but it's kind of close to a third of people in the US um, age 18 and older are pre-diabetic. So we got about 1 in 3 people. The cost of diabetes in the United States is just makes healthcare very expensive. Medical costs and lost work and wages for people with diagnosed diabetes total 413 billion when they redid the numbers for the current year. Medical costs for people with diabetes are more than twice as high as for people who do not have diabetes. All right, so why do people have diabetes? What is diabetes? So what happens when we eat? We eat food, pizza, um, bagels, meat, anything, any kind of food. Our body tries to turn that food into glucose. And of course, if we're eating carbohydrates, it's going to do that um, far more than if we're eating obviously something highly protein. But so we're focused on our carbohydrates. So the body takes glucose, and that's its main form of energy. That's what it wants, really, for its main form of energy. So most food is turned into what we call the blood glucose. It's the glucose in the blood that the body is going to take as its main source for energy. But it's got to get that glucose out of the blood and into the cells. So glucose is a sugar. It's taken up into the cell, and it's used for energy. But how does it get into the cell? So glucose gets into all the cells with a hormone called insulin. It's a hormone that's made and secreted it's in the pancreas, and it's made specifically by beta cells of the islet of Langerhans. And they are just sort of called into action when the glucose in the blood goes up. Then that insulin hormone is called into action and it comes down. Your body releases it sort of on an as needed basis. So you can see it acts like a key. And now we have the glucose in the cell. So that's our little animation. So normal glucose control for people without diabetes, glucose stays in a healthy range because insulin is released at the right time in the right amount. So they don't necessarily get hypoglycemic. They don't necessarily get hyperglycemic. Their body can sort of regulate, and people usually eat, in regulation. So they don't get these huge spikes and swings. So what is diabetes? There are three possible reasons, star, star, star. There are three possible reasons why somebody could have diabetes. They either have too little insulin Or we could also say they have no insulin, their body is not producing it. But so we can start out by saying too little or no insulin. Their liver is releasing too much glucose into the bloodstream. So when it's digesting the food and it's pulling off the glucose and things are metabolized by the liver, it's pulling out, it's shooting out too much glucose into the body, and the body can't handle it, can't break it down. Cells are not utilizing insulin well. So those are our three things. You want to memorize those. No insulin or not enough insulin. The liver is releasing too much glucose. Cells are not utilizing insulin well. Sometimes you hear insulin resistant. That's people who are not utilizing insulin well. So here's another slide that basically says the same thing. In diabetes, blood glucose builds up for several possible reasons. Too little insulin is made, liver releases too much glucose, can't use the insulin well. For prediabetes or diabetes, we have these numbers. We have diabetes, the A1C, which is the A1C stands for the, oh shoot, oh my gosh. It's the HB. Oh, I cannot believe I cannot remember this. It's hemoglobin. Okay, well, it's going to be written somewhere. That drives me crazy. Anyways, the A1C on someone with diabetes is going to be above 6.5. In the pre-diabetic range, where it's 5.7 to 6.4. And the normal is up somewhere about 5 or less than 5.7. And then you can see the other numbers that correspond. You should be generally familiar with these numbers and be able to think about, below this number. Sorry, people are talking. Never seen this. So we have two types of diabetes that you want to be familiar with. Type 1 diabetes is autoimmune, and that's really important to remember that it is an autoimmune condition. Typically comes on early in life and is defined by the lack of insulin production or too little insulin being produced by the pancreas. These patients are insulin dependent and they will be insulin dependent their entire lives. This is something where usually once the disease rears its head, generally speaking, people are no longer able to really produce any insulin at all. Type 2 diabetes is when generally there is enough insulin being made, but the cells are not utilizing the insulin well. With this type, the pancreas may stop making enough insulin over time. Type 2 usually comes on later in life, but we are seeing an awful lot of children with prediabetes or even with type 2 diabetes as well. And in the slide, embedded in the slide, is a good video to watch. So again, just basically reiterating the same things. Type 1 diabetes, formerly known as insulin dependent, is an autoimmune disease. We got about 5 to 10% of people who are diagnosed with diabetes have type 1. Most people are under the age of 20 when they are first diagnosed, but it can actually develop at any age, although it's not as common. And then the body can no longer make insulin. That's the key takeaway. It is an autoimmune disorder, star, star, star. Hyperglycemia is secondary to insulin deficiency. So there is no insulin to carry the glucose into the cells, so the patient becomes hyperglycemic. But it is not their hyperglycemia that sort of designates their disease. It's the insulin deficiency. Okay, so funny story. I paused the recording and I talked a whole bunch, and then I went to pause the recording again and I realized I hadn't unpaused it. So I'm not exactly sure where I just left off before I paused the recording. So I'm sorry if I'm going backwards or repeating myself. I'm so mad at myself. I can't believe I did that. So, okay, I'm going to start with type 2 diabetes. This type 2 diabetes is when the body cannot use insulin properly. So typically we see this in people, older people over the age of 40, but it's far more common nowadays for children to be diagnosed with type 2 diabetes. A lot of time it is a lifestyle connected condition, and people can reverse type 2 diabetes with some lifestyle changes. Very oftentimes we see people who have, in general, maybe uh, maybe a poor diet, maybe there's some other health problems. Perhaps oftentimes we see overweight, not a lot of exercise. It can be more prevalent in specific ethnic groups or if there's a family history of type 2 diabetes. This chart just kind of shows how in the 40s through the 80s, it was almost unheard of to see children being diagnosed with type 2 diabetes. And once we got into the late 90s, early 2000s, it all of a sudden exploded and became much more common to see children being diagnosed with type 2 diabetes. Just like with type 1 diabetes, hyperglycemia is secondary to insulin resistance. This is a really important point for both type 1 and type 2. It's oftentimes you're going to be quizzed on it on an exam. So hyperglycemia is not the main cause of the disease. The cause of the disease is an insulin problem. Hyperglycemia is downstream. It's secondary to that insulin problem. And with type 2, it's insulin resistant. Insulin production may be sufficient, but the body is not utilizing it right. So we call this a decreased sensitivity to insulin. Symptoms for type 2 come on more gradually than type 1. Type 1 come on fast, type 2 come on gradually. People can be pre-diabetic for a very long time, but there are some overlap in symptoms: increased thirst, urination, feeling tired, blurred vision, more frequent infections. Long-term complications can very negatively affect kidneys, eyes, nerves, feet problems. People can have neuropathy, periodontal disease, and heart disease. There is an increased risk for large blood vessel damage. So heart arteries, this is a healthy artery, this is atherosclerosis, but macrovascular complications mean higher risk for stroke, heart attack, general poor circulation, which of course can lead to other problems. Microvascular complications are going to be more nerve damage, so we call that neuropathy, small blood vessel damage that can cause blindness or kidney disease in someone who's been very sick with diabetes for a long time and it's uncontrolled. High blood sugar over time damages the nerves and weakens the walls of small blood vessels that supply nerves the oxygen and the nutrients that those nerves need. So that's what's going to lead to complications: poor infection control, poor wound healing, kidney disease over time, and other comorbidities that somebody may have who has diabetes. One of the biggest things that you need to be very, very educated on as a dental hygienist is the connection between dental disease risk and diabetes. So here we have some facts that you should try to memorize and learn. People with diabetes have twice the risk of having periodontal disease, as well as increased risk of dry mouth and fungal infection, so candidiasis. People with poorly controlled diabetes, that would be an A1C above 9%, are 3 times more likely to have severe periodontal disease. 1/3 of people with diabetes have severe periodontal disease with loss of attachment, missing teeth, gums to teeth, attachment of gums to teeth, sorry, I'm reading that wrong, and then periodontal probings 5 millimeters or more. And then the role of periodontal inflammation is a major component in the pathogenesis of diabetes and its complications. We call this whole phenomenon with periodontal disease and diabetics as a bidirectional relation, and sort of a negative bidirectional relationship. So we have a phenomenon where if somebody has high blood glucose and it's consistently, their blood sugar is consistently high, that person is going to have a harder time um, dealing with infections in their body and healing wounds and getting rid of infections. At the same time, somebody who has a chronic infection, such as periodontal disease, and they have diabetes, they're going to have a harder time controlling their blood glucose. So one thing affects the other. It's a vicious cycle. It's a negative cycle where high blood glucose negatively impacts infection control and getting rid of, dealing with chronic infection. And chronic infection, such as periodontal disease, negatively affects trying to stabilize and manage high blood glucose readings. So this is a vicious cycle. I'm going to stop there and we're going to do an intro to thyroid. Okay, so we're jumping over to thyroid and we're going to do an introduction here. So again, these are the objectives, but I don't know how far I'm going to go, so I'm not going to read those at the moment. The endocrine system as a whole are all these different, it's a collection of glands. They all produce different hormones. There's a lot of roles in regulation of metabolism, growth and development, tissue function, sexual health, reproduction, sleep, mood. They're incredibly important. So there's all sorts of different parts to the endocrine system. Really, we're just going to talk about how that relates to diabetes because we have those the insulin, the hormone, and then we're also going to talk about the thyroid, and then we'll talk about. We're not going to so much go into the pituitary gland. We do touch on it just a little bit here in a minute, but mostly the rest of the hormone talk will base more around female and male hormones and oral contraceptives. But so this unit here is solely on the thyroid. Okay, so thyroid function. The thyroid is a butterfly-shaped gland that is located on the front side of the neck, just below sort of where the Adam's apple would be. The thyroid gland has produces hormones that regulate metabolic rate. That is the speed at which a cell performs the different functions. It's important for carbohydrate, protein, and fat metabolism. Super important, helps to regulate blood pressure, and super important, helps to regulate growth and development. Thyroid hormones act on virtually every tissue and organ in the body. Super important for overall metabolism, growth, and development. And so it's very important organ. So the gland produces two different hormones. We have tetraiodothyronine or thyronine or T4. We'll just call it T4 in this class. It's also called thyroxine. It is a major hormone secreted by the thyroid gland, requires iodine for synthesis. So it's super important that we get iodine in our diet. And some people do have to supplement that. And then we have T3, which is triiodothyronine, these big words, and we can just call it T3. It is the active form of the thyroid hormone. So at the target tissue, T4 up here is converted to T3. So T3 is what really does the work, but most of what we produce is T4, and then a little bit becomes T3, and that amount of T3 does the work. T3 enters the target cells, binds to intracellular receptors, and becomes the active form of the thyroid hormone. So about 87% of T3 is derived from T4, so T4 will eventually become T3. And then that small remaining 13% is synthesized in the thyroid gland and actually is making the T3. Iodine is required for synthesis of T4 and must be acquired through diet or supplementation. Once released into the bloodstream, thyroid hormones can exist in the bound to a protein or unbound form. So it is a highly bound hormone, though. So almost all T4 is going to be bound up with protein. So it's only going to be released a little bit at a time. So the notes here, I always like to read my notes. The normal function of the thyroid gland requires an adequate intake of iodine. Marine life is a common food where people that naturally, but if you don't eat a lot of seafood, then you might have to supplement. Most of the thyroid hormones in the bloodstream are bound to protein. So it's a highly protein bound hormone. Which makes them totally inactive. You remember that. If something is bound to a protein in the blood, it's not doing anything. It's just floating around the blood. If the body needs more hormones, T3 and T4 can be released from these proteins in the body to go do their job. So they're kind of ready to go do the work. Thyroid gland hormones, so way up in the hypothalamus and also the pituitary gland, thyroid stimulating hormone, or TSH, is released, and that stimulates the thyroid to produce T4 and T3, right? So thyroid stimulating hormone from the anterior lobe of the pituitary gland stimulates the release of T4 and T3, and then they synthesize and secrete the thyroid hormone. So when the body says, oh, I'm low on T4, that triggers the pituitary gland. It's called a negative feedback loop. It triggers the TSH to be stimulated and released, which then stimulates the thyroid. So here's a little in the notes, this describes that process. The negative feedback loop, constant communication with the thyroid gland. TSH declines as blood levels of thyroid T4 rise and vice versa. So if T4 lowers, then TSH will increase. As T4 rises, TSH declines because you don't need both. So they kind of self-regulate. It is in a constant loop of increasing levels and then decreasing secretion when the levels are up. TSH levels high, T4 is likely low. The body thinks it needs more. TSH levels low, T4 is likely high. The body's not signaling that TSH is needed because T4 levels are high. So it's just basically when one is low, the other is high. When one is high, the other's low. It's a negative feedback, and that's how it would normally function healthy. If it's not functioning healthy, then we get an imbalance of our levels. This is just another little description. We have the thyroid hormone releasing T4. It stimulates the pituitary gland to tell it whether or not to release more TSH. And the same with the active form T3. So for the thyroid disorders, we have hyperthyroidism and hypothyroidism, blood tests that measure the unbound. Remember, it's highly bound. So blood tests can be tricky, but blood tests is taken to measure unbound or free. Sometimes they just call it free T3 and T4 or TSH levels. And so basically in hyperthyroidism, there's increased serum of T4. And why is that? That's because there's all this T4, but TSH is not kicking on, saying, you're going to see increased, if they have hyperthyroidism, you're going to see high levels of T4 and you're going to see low levels of TSH. Now, alternatively, oh my gosh, I can't say the word. Alternatively, good grief, if you have hypothyroidism, you're going to have decreased levels of T4 and very high levels of TSH, but it's not kicking on. It's not doing what it needs to do to get the T4. T4 should come up and then shut off TSH, but it's not. That's hypothyroidism. So basically, when the levels tell the doctors what's going on if people are exhibiting symptoms. Hashimoto's thyroidosis is a condition. It's an autoimmune condition that is destructive to the thyroid gland. The person who has Hashimoto's may initially develop a goiter, so they could show a hyperthyroidism initially. TSH levels rise in the beginning. As Hashimoto progresses, it progresses into hypothyroidism. Patients may gain weight, feel sluggish, cold, and have a slowed heart rate. A goiter or an enlarged thyroid, this is a very enlarged thyroid, um, is an inflamed or enlarged thyroid gland. It can be a result of both either hypo or hyperthyroidism, or it could be severe iodine deficiency. Hyperthyroidism, it's also called Graves' disease. It's the most common autoimmune disease there is. Signs and symptoms of, if undiagnosed, sweating, weight loss, nervousness, oversensitive to heat, fatigue, moist skin, tachycardia in Graves' disease. There can also sometimes be a bulging of the eyes. Increased heart rate, beta-adrenergic antagonists may be used to relieve these symptoms. What's another name for this kind of drug? What's another name for a beta-adrenergic antagonist? And I'm just going to put that out there and see if you guys remember. Something with an S, starts with an S. Okay, so here's a picture with hyperthyroidism and the Graves' disease and sort of the bulging of the eyes. So when the immune system attacks the tissue around the eye, it causes the eye muscle or fat to expand and it pushes on the back of the eye, results in inflammation and a buildup of tissue that pushes the eyes out. Okay, so we're going to stop there because have we're gonna just do the drugs in class. So we're gonna stop there. Okay, and our last bit, I have no idea how long this PowerPoint has been, hopefully not too long, is other endocrine disorders. So I'm going to go through this whole PowerPoint. So I am going to read these. So we want to summarize major female and male sex hormones and describe several types of hormonal contraceptives. We're going to discuss other agents that affect sex hormone systems. We're going to discuss oral considerations related to endocrine glands and identify dental hygiene considerations. So again, just like I said for the thyroid at the beginning of the thyroid, the endocrine glands include the pituitary, thyroid, parathyroid, pancreas, that's where we get our diabetes talk, adrenals, gonads, and placenta. They all are considered part of the endocrine system. Collectively, they maintain homeostasis. They're controlled by feedback systems, just like that negative feedback loop for the thyroid or insulin. Also, it's a feedback loop. Patient may be taking hormones for various reasons, all kinds of different reasons someone might take hormones. Drugs that affect the endocrine system include the hormones secreted by the endocrine glands, synthetic hormone agonists, antagonists, and substances that influence the synthesis and secretion of hormones. The pituitary is a small gland located at the base of the brain, releases peptide hormones from the anterior and posterior lobes. We already learned that TSH, or thyroid stimulating hormone, is released from the anterior lobe. If somebody has pituitary deficiency, they can have a loss of secondary sex characteristics. They can have decreased metabolism, dwarfism, diabetes insipidus, hypothyroidism, Addison disease, or slowed dental development if this happens when they're young. If they have hypersecretion, they could have sexual precocious, oh my gosh, precocity, but I think it's for the word precocious. Precocious puberty is another way that they say it. Goiter, so related to thyroid. Cushing's disease, that's related to the adrenal gland. Acromegalia, I think that's growth, and giantism is related to growth. Conditions patients may be taking hormones for. This is collectively, this is very broadly speaking. Patients could take hormones to treat infertility. They could take it to induce ovulation. Patients can take hormones to treat different cancers, such as prostate cancer, endometriosis. This drug up here is a dopamine agonist. It's a hormone, but it's a dopamine agonist, and so that can be used to treat Parkinson's disease. Hormones are used to induce labor, oxytocin, transient diabetes insipidus. Vasopressin is a hormone that's used to treat this form of diabetes. And then off-label, people could also use hormones for transgender therapy. Also, hormones are obviously used as contraceptives as well in birth control. For female sex hormones, we're going to there's a lot more to talk about, but we're going to just very broadly say estrogen and progestins or progesterone. They're secreted primarily by the ovaries. They produce female characteristics. They develop the reproductive system, and they prepare the reproductive system for contraception or for conception, sorry. Drug examples would be conjugated estrogen, Premarin, esterified estrogen, Menest, estradiol, estrase, birth control examples, Ocella, NuvaRing. There's so many different different compounds for hormone drugs. I just can't really put a whole bunch. I'm probably not going to test you heavily, but it's probably fair to say that if you see the word estrogen in something, it's a hormone that I would try to commit that to memory. Side effects of estrogen therapy: nausea, vomiting, uterine bleeding, weight gain, hypertension. That's important. I'd star that. Other side effects for hormonal contraception: blood clots and liver damage. So effects on oral tissue, estrogen related, increased incident of post-extraction dry socket. That's more specifically during a certain time in a woman's ovulation cycle. Cloasma or melasma, use caution with a dental light. Increased susceptibility to candida. Check after antibiotic therapy. Decreased glucose tolerance, check blood glucose levels if needed. Increase thromboembolic disease, blood clots, so we have to be cautious there. Antibiotics are said to reduce effectiveness of oral contraceptives. Highlight that one for sure. These agents can increase blood pressure, so we want to make sure we check blood pressure. Gingivitis, periodontitis, more frequent recalls if somebody is showing signs of inflamed gingiva during hormone therapy, pregnancy, anything that increases or changes hormone levels. Patient may be taking calcium supplementation for bones. She should avoid sorry, don't know how to say that word at the moment. My brain's going bye-bye. Concomitant. Calcium supplements with tetracycline or doxycycline. So there we have a drug interaction with calcium. If somebody is on heavy progestin or progesterone, again, this melasma or cholasma and thrombophlebitis or blood clots. Dental drug interactions with oral contraceptives, penicillin and tetracycline, we're worried about the decreased effectiveness of oral contraceptives. Acetaminophen is hard on the liver, that's Tylenol, and so can oral contraceptives. So you want to be cautious there, especially if somebody has a bad liver, if they have liver disease or something. Benzodiazepines increased clearance time, so they don't clear as quickly if someone's taking certain oral contraceptives. For male sex hormones, we have testosterone's our main one. So if somebody is taking testosterone, an FDA-approved indication would be if they're deficient in testosterone to stimulate puberty in boys, if they're delayed starting puberty, if it's in some estrogen-dependent malignancies in females, they may also prescribe testosterone. Other agents that affect sex hormones, these agents act like hormones or inhibit the action of natural hormones. The hormones from opposite sex may be used in various diseases, conditions, or cancers. And so an example here, I'm just giving you one. There are many, but I'm just keeping it simple here. Clomiphene or clomiphene is a fertility treatment. It is a partial estrogen agonist. So it's not a hormone, it's just an agent that acts like a hormone. It's a partial estrogen agonist. It causes the body to produce more luteinizing hormone and follicle stimulating hormone. So these are hormones in for the fertility process. So pay attention to the gingivitis risk because that's messing with people's hormones. So it could affect their gum tissue, be more prone to gingivitis. And then if somebody's taking this drug, um, clomiphene, you can assume they're probably pregnant because they're very likely trying to get pregnant. And then they are, interesting to note, 6 times more likely to have multiple pregnancies, so twins or triplets. Here are some overall dental considerations in general when we talk about different hormones, but mainly the sex hormones is what this is concentrating on here. The dental hygienist should review the importance of good home oral hygiene with all patients who take oral contraceptives because the potential for gingivitis or gingival inflammation is increased. Here we have that dry socket risk, but mostly it can be avoided um, if they perform the extraction between day 23 and 28 of a woman's cycle. Always check patients' blood pressure. They're at a higher risk for high blood pressure. They're at a higher risk for blood clots, so people need to stretch. They shouldn't be kind of cramped up and not be able to move. There was, I should have taken that one out, sorry. Patients taking anabolic steroids, so anabolic steroids or male sex hormones, could be prone to mood changes. So if someone seems aggressive or psychotic, probably want to reschedule your appointment. Anabolic steroids and male sex hormones can also elevate blood pressure, so you want to be very aware of blood pressure risks, blood clots, mood disorders, gingivitis. These are our main things. And then the decreased effectiveness of oral contraceptives with antibiotics. Those are your major take-home points for these sex hormones topic. And sorry, that lecture bite probably is a little bit longer than I wanted it to be, but that's the end of that.